radiation oncology. He's in the neuro-oncology cancer center cancer group, and he's currently at the Apollo Proton Cancer Center at Chennai, India. And today we're excited to hear an interesting talk on the impact of modern proton therapy on improving survival and survivorship in pediatric brain tumors. So welcome, Dr. Krishna, and please you may start and give us the talk.
Thank you so much to the Society of Radiation Oncology, Dr. Algamdi. I can't believe it's about 3 years that we met in UFPTI, and to all my friends from Saudi Arabia, a very good evening and namaste from India. So I would like to know exactly how many minutes do I have for this talk?
You have around 35 to 40 minutes, and then 20
Sure.
minutes we'll open it for the floor.
Sure. Okay. All right. So that I can space my slides based on that. All right. Thank you so much. So to begin with, so we, as a part of the neuro-oncology group in Tata Memorial Hospital, in the year 2016-17, we demonstrated a level 1 evidence through a randomized control trial, which looked at efficacy and safety of stereotactic conformal radiation therapy versus conventional therapy and benign and low-grade brain tumors. And this was published in JAMA Oncology, and commentaries from leaders in neuro-oncology like Dr. Nancy Mendenhall from UFPTI, which showed that when you are comparing a high-end high precision modality like SERT back those days, because this trial was about 15 years. It ran for about 10 years. So it started in 2001. So back then it was called SERT. SERT provides significantly less neurocognitive and endocrine outcomes and excellent survival. The significantly better neurocognitive and endocrine functional outcomes with SERT compared to conventional RT. And recently, our update of 10-year survival of craniopharyngiomas published in Neuro-Oncology, we showed that excellent survival, excellent long-term control, preserves function in pediatric craniopharyngiomas, and the local overall survival was, the 10-year overall survival was about 86%, and local control was about 93%. And what we termed as freedom from cognitive decline at 5 years was higher with SERT, which is significantly better than craniophryngio, better than conventional radiation therapy, which means that if you treat smaller volumes of normal tissue, there are going to be significantly superior clinical outcomes, especially when you're treating benign and low-grade tumors, especially if you are treating children. So what if that is the story with smaller tumors? What happens when you're treating large volumes, especially like craniosspinal irradiation? We know traditionally there have been multiple techniques to treat craniosspinal irradiation like 3D CRT, static IMRT, VMAT or rapid arc or tomotherapy. And if we can compare these modalities with various indices like ease of planning, PTV coverage, conformal homogeneity index, OIR sparing, junction matching, etc., what stands out is even with the best possible photon technology like tomotherapy, there's going to be a highest integral dose, which is dose deposited per kg of mass, which is measured in joules, either in child or in an adult. And as you treat larger fields in a smaller volume, in a smaller length, like a child, these integral doses are going to be very high. So when they looked at these effects of these integral doses, especially on the red marrow and on the bodily structures, these can have significant impact on long-term survival and quality of life. A very good editorial from a very good article from New England Journal of Medicine in 2006, which looked at chronic health conditions in adult survivors of childhood cancer, showed that 62% of these children who are alive in long term with after being treated for a childhood brain tumor or a childhood cancer have 1/3 of these children have at least one significant long-term related side effect. 1/3 of them can have severe life-threatening cancers, life-threatening problems. And many of these are basically because of adverse effects of radiation therapy. So people like Tom Merchant looked at what is the advantage of proton therapy in these situations. If you compare serial organs or parallel organs like the brain, the temporal lobe, cochlea, and hypothalamus, and when they just ran dosimetric studies, they found that there was significantly better outcomes with proton therapy in this population compared to photons. So a very good review by Vinay Gandhi and team, and also there is a cohort study from Mass General Hospital which looked at children treated with conventional radiation therapy from 1973 to 2001, and while they compared the same number of children with who were treated with protons between 1973 and 2001, they showed that the hazard ratio with protons was as much as 0.52. So what that means is protons with a biological and a physical property of stopping in tissue. The first figure, what I'm trying to show in the highlight, is because of the lower entry level dose of proton therapy, it peaks at depth, and then there is sharp fall off of dose in the depth of tissue. The yellow component for the non-radiation oncologists in the crowd, if there are, then the yellow component is what is the additional radiation dose, what an X-ray can deposit. So this essentially is one proton therapy beam. So if you could bring proton therapy beams of multiple energies, one behind the other, and create something called a spread out Bragg peak, and this being brought from multiple different directions, you can essentially understand that the entry level radiation dose is going to be 25% of what a photon beam can do, and literally there is no exit beam at all in proton therapy. And proton therapy is known to be more densely deposited because they are directly charged particles, and they have got multiple other secondary changes happening in the tissue as compared to the photons, and henceforth the biological effects are much significant. Protons, because of the mass being about 2000 times heavier than electrons, it is possible to make sure that these effects are augmented. And as most of us know, because of its uncertainty at the end range of this proton therapy, a lot of side effects, a lot of changes have happened in the way proton therapy has been planned, the proton therapy has been delivered, and how the proton therapy has made progress over many years. So as we know, protons compared to photons are extremely labor intensive, extremely time intensive. From the imaging, simulation, pre-planning checks, delineation, planning, evaluation, it takes almost 3 to 4 times the time of what a normal photon therapy can take. Quality assurance takes a longer time. Quality assurance imaging takes usually about 2 hours. Delivery is quite longer compared to the conventional radiation therapy. Adaptation and review of treatment imaging usually takes 2 working days, which usually is not necessary in photons. So what about the data availability on proton therapy? We have very few randomized controlled trials, especially if those who attended Astro a few months ago, a few days ago, would realize that only few randomized controlled trials have shown superiority of proton therapy. There are a number of cohort studies which suggest superiority or equivalence in tumor control and favorable toxicity, but there are enormous dosimetric studies to show that there is advantages of proton therapy compared to conventional radiation therapy. So essentially, when we compare two different modalities, what people try to do is compare the toxicity outcomes of this. So if we go back in time and look at those studies comparing the passive scattered proton therapy, which is the additional traditional technique or the contemporary technique, when they compared that with X-rays, especially for a CSI in medulloblastoma, as early as in 1991, you can see a paper from Loma Linda, which is considered as one of the earliest PSPT centers in the world. It showed that the number who benefited with proton therapy was significantly higher compared to those with conventional radiation. People try to look at ototoxicity, people try to look at radiogenic cardiotoxicity, people try to look at the nadir of hematological toxicity with proton therapy. People try to look at premature ovarian failure rates with IMRT compared to conventional radiation compared to proton therapy. People have tried to look at pancreatic DVHs when you do with proton therapy compared to conventional radiation therapy in craniospheric radiation, and they have found that dosimetrically in all these scenarios, proton therapy is much superior. But is that enough to go ahead and say proton therapy is the essential treatment for all these cases? So what many people have done is people have tried to look at other components of treatment like the neurocognitive decline, quality of life, memory by various indices across various study groups, whether it is Europe or US, or whether it is on very young children, or whether it is on young adults, or whether it is adults. They have found significant superiority in terms of neurocognitive decline, quality of life, and memory. Is that enough? Do we have survival data? Yes, especially in brain tumors, we have survival data. We know from Tom Merchant's data that a phase 2 study of passive scattered proton beams comparing proton beam therapy after a minimal surgery or a biopsy surgery with cranopharyngioma, and trying to get only a histological evidence with other things like shunt, etc. And they gave proton therapy compared to photon therapy. They found that proton therapy provided significantly improved a 5-year overall survival compared to photon therapy. Especially with ependymoma, there are meta-analyses which have shown that, and especially the large study from Dr. Indelicato's group of UFPTI has shown that 81% overall survival among follow-up of all ependymomas. Please note that these are all ependymomas. They are not just general supratentorial ependymomas or posterior fossa. So it's a mixed bag. So it shows about 81% overall survival benefit at 5 years. And when it comes to medulloblastoma, people have shown that in standard risk or average risk, there is definitely improved survival, especially when it is a classical or desmoplastic medulloblastoma compared to anaplastic medulloblastoma or large cell anaplasia. And what about secondary malignant neoplasms after treating a large field like CSI? When you compare X-ray and modern proton therapy, the average risk or the lifetime attributable risks is about 4 times higher with conventional radiation therapy compared to what a proton therapy can do. And like I told previously, the integral dose is quite high compared to proton therapy. So over years, as we all of us know, there has been evolution of proton therapy from a passive scattered proton therapy to a more active scanning or something called as a pencil beam scanning proton therapy technology. So when an institution has to adapt from an older technology to a newer technology, there has to be significant evidence to show that the passive scattered technique can be much better. Physics point of view, we know that there is no hardware in the beam of the radiation. This is more of a magnetic scatter, and you use double scattered, and you use more of a pencil beam scanning with 2 pairs of magnets to make sure that you bring various energies scanned across the beam and treated as spot by spot, layer by layer, instead of treating them as a whole like previously. So people have tried to do gamma H2AX assay between these two techniques. They have tried to do caspase apoptosis measurement over time when you treat with active scanning versus passive scattered. They have liked to look at clonogenic cell-free survival data, cell survival data with the passive scattered, as well as pencil beam scatter technique, as well as double scattered technique. And they have found that somewhere the active scanned or pencil beam scanning proton beam therapy is quite superior compared to the traditional passive scattered proton technology. So what is the real challenge in the present data available of proton therapy is that most of this data comes from the traditional era of passive scattered. So the more modern pencil beam scanning has got image guidance. It has got no collimators, so there is no neutron contamination. It is based on the concept of robust technology. So although there are range uncertainties, which these can be taken into consideration with something called as robust optimization, we use Monte Carlo algorithms, which are more accurate. The spot sizes can be as small as 3 millimeter. And of course, there is now possibility of doing LET evaluation or optimization or variable RBE modeling to make it more biologically superior. So Apollo Proton Cancer Center was initially conceptualized in 2012, 2013, and over years, as you can see here, it took various stages of development, and finally in January 2019, we started the proton therapy treatment for the first child here with a cranopharyngioma. So far, we have treated close to 2,400 patients a day. The minimum age of the child is about 11 months old child with an ependymoma, which had a very aggressive course. And so we had to treat immediately after the second surgery without delaying much. And the oldest patient we have treated was about an 89-year-old patient with a endometrial malignancy, which was deemed to be inoperable. So we have had the various histologies, as you can see, and about 30% of these children 30% of these patients are predominantly children. and we are one among the 4-5 campuses recognized by IBA as a leader in proton therapy and for training and development of proton therapy for other centers. So Apollo Proton Cancer Center treats patients by something called as a cancer management groups. So we have various cancer management groups for the brain tumors, head and neck, pediatric oncology, urology, gastrointestinal system, thoracic, and breast gynae. It's not just a cancer center. It's not just a proton therapy center, but it's a sophisticated, high-end, comprehensive tertiary care cancer center with medical oncology, state-of-the-art surgical oncology, robos, and imaging platforms, including pathology. So every single patient who was eventually selected for proton therapy goes through a very essential process called a peer review process in a room called ISO Center, wherein each and every patient's plan has been in detail discussed with in presence of the oncologist who's treating, all the oncologists of other CMTs, the physics department, and the technology department, so that all of us have got a peer review process, all of us raise questions about a plan, and then eventually the patient's plan goes through the system, and then it is implemented after a very stringent QA process. So neuro-oncology cancer management team where I work has got two senior neurosurgeons. Dr. Rakesh Jalali is the convener of the CMT. I'm a part of the radiation oncology group. We have the very senior pathologist who is American board certified, a very senior pediatric oncologist, and a neuroradiologist of repute. We discuss close to 2,100 patients a year for consideration of proton therapy for neuro-oncology, 7 to 80 patients per week we discuss in the MDT. Eventually, about 10% of these patients eventually get translated into getting treated with proton therapy. So we close to treat about 210, 220 patients in a year with proton therapy. It's not just about the proton therapy or the radiation oncology management. It's a holistic neuro-oncology management. We do reviews of the pathology. We do NGS. We have got methylation profiling within collaboration with Heidelberg and NIH, and we collaborate with multiple other centers across various parts of India. So when we look at indications in a nutshell, where proton therapy may really be beneficial and where it may be useful, and if I can break them down into 4 different situations, proton therapy is beneficial when your target volume is in close proximity to any critical structure, and the underdosing of this can lead to a compromised overall survival. And when we look at this situation, you can get 2 examples. One is a chordoma and one is an ependymoma. In this, we are trying to optimize oncological outcomes, wherein there can be meaningful, higher significant normal tissue toxicity with photons. You are trying to optimize the acute and late toxicities. Examples of this are like the medulloblastoma, which need craniosmal irradiation, the craniopharyngiomas, low-grade gliomas, and intracranial germ cell tumors. Where the photons plans can be prohibitive, like the head and neck sarcomas, especially the rhabdomyoid sarcomas, and when it is re-irradiation, of course, proton therapy is a preferred option. So what I would like to do in the next few slides is take a case example of each of this and try to show our experience, and then eventually discuss the results, what we have tried to publish in the world in one of the peer-reviewed journals across the world. So chordomas, as we all know, is a locally invasive disease. There is no doubt that it needs a dose of 70 gray or more. There is National Cancer Database analysis of more than 1,500 patients. Various risk factors laid out. Proton therapy versus conventional therapy is beneficial. Dose of more than 70 gray is required. Chondrosarcomas compared to chordomas do better. And we also know that there are other factors which can play on a univariate or a multivariate analysis significant importance in management of these tumors better with proton therapy. One such case example here, one of the patients referred to us for proton therapy, we found that there was there was a dosimetric compromise if we treated this patient with zero gap between the tumor and the brainstem. So our neurosurgeons had to go in, create a fat spacer between the brainstem and the tumor so that the dosimetric compromise could be negated and we could get a most optimal plan and hence deliver a therapeutic radiation dose. So some small tweaks of routine treatments have to be made in the course of treatment for betterment of the patients. So most challenging aspect in this situation is presence of metal because of the stabilization of the spine. So at times we'll have to combine both the photon and the tomotherapy plans in order to attain the most optimal dosage in and around the cord, also the brainstem. So our experience with chordomas has been we have treated close to 120 patients. So along with the previous factors what I had enlisted before, we also have seen the two other important factors on a multivariate analysis were that if the GTV residue was about 25 centimeter cube or more, and if there was a compromise in the delivery of full therapeutic radiation dose in terms of tier 1 or tier 2 compromise, wherein you are not able to deliver more than 66 to 70 gray or various other factors, there can be significant decline in the overall survival over at least 2 years. So we had looked at 2 years of progression-free survival and local control. So as you can see, it is significantly better if you do not have a compromise and if you don't have a residue. So the aim of a treatment of chordoma should always be to achieve as small residue as possible, even if it requires a 3 or a 4 stage procedures to ensure we give maximum possible overall survival. So I would like to show a few case examples going forward. This was a 2-year-old child which came from Central Asia. And as you can see, it had got a right foramen of Lushka mass coming onto the posterior fossa. It was called a posterior fossa A ependymoma because of the H3K ME3 global loss in nuclear expression pattern. Post-operatively, sadly, this child received chemotherapy, which has got no role in an ependymoma, as all of us know. So the intention of radiation was to postpone the radiation because they thought radiation can cause increase in cognitive decline and other things. So what I have tried to highlight is here, I have tried to mark it on a red arrow, and I've tried to show the supratentorial brain, what you see here, the 30% or the 20% of the supratentorial brain receives hardly 3 to 4 gray. So my humble submission at this point of time is for a ependymoma, unless until the child is less than 1 year old, there is no indication for adjuvant chemotherapy. And all of us know that the ACNS 0831 is yet to come out with its result, and most of it is probably has not shown any significant benefit with chemotherapy. In an ependymoma, especially in a posterior fossa, especially in a young child, the push has to be to give immediate adjuvant radiation, and whenever possible with proton therapy to improvise the outcomes. So a second situation is a 12-year-old girl from Australia. Australia doesn't have proton therapy, so the family insisted in taking proton therapy only. She had a Wnt-activated medulloblastoma, and most of us know Wnt-activated medulloblastomas are the most favorable group, have close to 100% overall survival, maybe about 98% overall survival. So this girl had a complete removal, so it was no residue. There was no metastasis, and it was a classic histology with a monosomy of chromosome 6. So it comes under the category of W1 as per SJMB 12 randomized control trial. So if you can deliver 15 gray of CSI to this child, and if you can give 51 gray to the posterior fossa, the tumor bed, you are able to achieve 98% overall survival as per the SGMB 12 data. So what I have tried to show here is, even in a situation like this, even when the requirement of CSI is only 15 gray, in a 12-year-old child who may be towards the pubertal age group, who may have risk of exposure to the breast tissue or the abdominal tissue or the thoracic tissue, what I have tried to show is significantly improved dosimetry to the serial organs, to the parallel organs, as well as superior coverage of the target with proton therapy to make sure that you can improve this survival of 98% and also provide the best quality of life to these children. Next scenario is a 17-year-old girl from Abu Dhabi who had a myxopapillary ependymoma. They had run a plan on photons, and they realized that the dosimetry to other structures was significantly high. Myxopapillary ependymoma, we know from the John Hopkins data that as radiation as an adjuvant therapy it provides almost 100% overall survival compared to surgery and then treat with the delayed radiation. So we had to review the blocks, and I have tried to put the dosimetric comparison of a proton therapy plan on the right panel versus a phototherapy plan. And you can see on the red arrow that the ovary doses with proton therapy is hardly zero compared to what it was with tomotherapy. And you can also see the doses of kidney are negligible compared to proton therapy compared to tomotherapy. So in a girl who is about 17, 18-year-old in who the ovarian doses are of important significance, I think in a situation like this where it is curable and can provide 100% overall survival, we have to consider proton therapy compared to conventional radiation therapy. This was a child from South Africa, 6-year-old child, had an intramedullary spinal cord lesion. Sorry, it was an intermedullary with an extramedullary rim spinal cord lesion, which was called as a central neurocytoma, was referred to us for adjuvant radiation therapy because the radiation oncologists there, they thought that the doses to thyroids can be a little high. While the child was brought here and we did an MRI scan, To our surprise, we saw that there were immense leptomeningeal deposits in the supratemporal part of the brain. There were deposits in the lower part of the spinal cord and also in the sacral deposits. So what we did was, in a multidisciplinary decision, we decided to go ahead and treat this child with crinospinal irradiation. Although it was a 6-year-old child, it was quite difficult to convince the family. Our suspicion on the histopathology review was that it could likely be a little higher grade than just a pilocytic cystocytoma or a central neurocytoma. So we took a diagnosis of a diffuse glioneuronal tumor with oligodendroglioma-like features, which although is very quite rare, we had to convince the family and we started the CSI. And in collaboration of ours with Heidelberg, we had to get a methylation profiling. And to our surprise, when it came back, it was a diffuse leptomeningeal glioneuronal tumor, had a 1Q gain, had 1P loss, and a copy number breakpoint, which is characteristic of a pilocytic astrocytoma. So what that means is, although spinal cord tumors is rare in children, we have to be very careful. We have to keep our eyes open, and then we have to keep our minds open, and then to think laterally. And a multidisciplinary teamwork and inputs from pathology, radiology, and other people is very essential. And also collaboration of international centers to get more insights into these tumors are very essential, which is one of the focus and the fulcrum of neuro-oncology treatment at APCC. So next I come to a boy who was 7-year-old boy from Abu Dhabi, who had a posterior fossa mass, which looked like a posterior fossa B ependymoma. He underwent surgery in Abu Dhabi. He came here for adjuvant treatment. And for our surprise, there was chromosome 1q gain. Most of us know that chromosome 1q gain has attained a lot of enormous importance of late in presence of a posterior fossa A type ependymoma with a global H3K27ME3 loss. And these children can have predilection for CSF dissemination. So when we started treatment for this boy, we just gave focal irradiation only to the posterior fossa, to the tumor bed, and we kept screening the spinal cord over time. And to our notice, a follow-up scan of for 12 to 14 months, we sadly noticed that he had a deposits in the spinal cord, which is characteristic of this. So what, as a practice in our institution, what we have started to do is, after a ethical approval and on a IRB approval protocol, we are trying to recruit these children with a residual disease in the posterior fossa with a 1Q gain, or in children with a large disease before surgery and with clinical suspicion of spinal cord disease. And especially when we know that the child or the family may not be reliable for a close follow-up, we are planning to try and do crinospinal irradiation in these children to a dose of 35 gray and give radiation additional posterior fossa boost or the tumor bed boost in addition to it to a total dose of 54 to 55 or even 56 gray at times. So next, switching gears from ependymomas to cranopharyngiomas. All of us know cranopharyngiomas are quite challenging. There can be multiple complex issues, especially with proton therapy, because the cyst volume can keep changing. It needs weekly MRIs, needs adaptive planning. There can be shunt. So the shunt can have a different density. You will have to adjust to this as per this. So initially we started with something called as a single field optimization technique. And now, because of various other experiences, we have shown in our own initial experience of craniofaryngiomas that we can, provided with a very good MRI backup and close monitoring of these cysts and other factors, we are able to achieve a good overall survival. And so far the disease control has been 100%. We have about 50 kits from the beginning until date, and we have tried to demonstrate that it is 100% disease control and overall survival. We haven't had deaths so far, by God's grace. And we have just put up scans of 3 patients, which you can see over time, from pre-surgery to radiation planning and post-proton therapy 1 year, there can be significantly improved local control with proton therapy compared to conventional therapy in our own comparison of tomotherapy patients. So of late, we have been seeing a lot of cases of CMMRD, constitutional mismatch repair deficiency associated pediatric gliomas, one of the main reasons for high-grade gliomas in children. So one of the such cases wherein we saw that there was a lot of filler abnormality on the contralateral brain, not a classic gliomatosis picture. And we took a biopsy and surgery from this, and we look at the family tree. There was significant family history of cancers in this patient. So we did NGS, and for our surprise, there was PMS and MSH2 loss on the immunohistochemistry, which was confirmed on the NGS as well. So what we have tried to do is we try to avoid giving radiation, avoid giving temozolomide in these patients, although it is a glial lineage and IDH mutation. we try to put them on radiation therapy alone. And because of our collaboration with the Sick Kids in Canada, we are able to do further analysis of these patients and try to put them on immunotherapy based on the tumor mutation burden, and also if there is significant volume of the burden of the disease in the brain, we try to put them on adjuvant temozolomide. And our initial experience has been quite encouraging. And although we need a longer term follow-up to establish more, so over time, we have identified many such situations, many such clinical situations wherein children had Lynch syndrome or CMMRD at various age groups lasting from 4 to 40 years, even in adults. And we have tried to personalize the treatment for all these patients. So lastly, our strength of Apollo Proton Cancer Center has been in craniosspinal irradiation. So as all of us know, CSI with proton therapy with the modern pencil beam scanning comes from Paul Scherrer Institute in Switzerland, where Tony Lomax and team demonstrated that with spot scanning technology, it is ideal, it is very easy, or it is rather more easier compared to passive scatter technique to deliver dose, so that the ventral dose distribution and the frontal subarachnoid space are not compromised. It is less fragile for hot and cold spots, and the matching of the multiple fields can be avoided. So Apollo Proton Cancer Center, as early as in 2019, 2020, developed this technique of delivering the radiation posteriorly to brain as well as spinal cord. But over time, we have now customized our treatment to bringing two anterior beams and one posterior beam for the brain and the upper spine, and two or one posterior direct spinal fields for the spine. This paper is available in Clinical Oncology. I request most of you if you would like to read. So we have made some small modifications in the way it was traditionally described. So we have made our own protocol, our own beam geometry, our own way of optimizing the robust optimization, the setup parameters. Everything is very well defined. Over years, we have been analyzing all these things. 30% of our patients need anesthesia. So the way we have to immobilize these children, we know that the density of the base plate has to be uniform along the entire craniosspinal axis as compared to photons. The way we define the entire vertebral body, the way we give CTV for the PTV for the brain, for PTV for the spine. For the skeletally immature children, we take the entire vertebral body to make sure they don't develop curvature abnormalities later. And for children with already who have attained puberty, we try to spare vertebral body. The typical beam arrangement is one called a spot assigning structure for the brain and upper spine, the upper spine and the lower spine, and the overlapping regions are maintained approximately at 5 to 8 millimeters. It's usually a CTV-based robust optimization, efficient and robust against setup and uncertainties. And we use typically between 70 and 200 MeV protons based on what is the depth of the tissue, depth of the cord, and then the girth of the patient. So the plan optimization and the plan evaluation is usually the routine way of doing this. And on the setup on day one, we take X-rays and then followed by CT scans. We try to make sure that we keep the setup variation not more than 5 millimeter in any direction, or less than 1 degree initially. And then we repeat CBCTs to make sure that this is less than 2 millimeters or less than 3 millimeters based on age of the child and the length of the spine. And then this is lowered to about twice weekly compared to every day to twice weekly. And then eventually, once we have established what are the shift patterns, then we try to make it as less as possible. The CBCs are done at least once in a week. We evaluate these children every week to assess. So we have treated so far close to about 197 children. We are going to be presenting this data in the PTCOG Asia Oceania in the next week in Hong Kong. So the youngest child we treated is about 1 year of age with ATRT. More than 30% needed IMPT under anesthesia. The cranospinal lengths of close to 80 centimeters we have treated. With a median follow-up of 40 months, we have achieved overall survival of about 84%, PFS of 70%. Germ cell tumors of the brain have done extremely well compared to anaplastic recurrent ependymomas, who have had a very poor survival of 44%. And we are going to be presenting and publishing this. I've just put a snapshot of a few of the patients of medulloblastomas. We have treated most of the subgroups. Wnt SHH have 100% survival compared to group 4s who have 95% and group 3 have 60%. And the overall medulloblastoma cohort has got an overall survival of about 84%. So we have published various outcomes of most of these patients in various leading peer-reviewed journals. So I will try to talk more about ependymoma and then I'll close my lecture. So ependymomas, we know the evidence for adjuvant radiation therapy comes from ACNS 0121, wherein if you look based on the grade of the ependymoma and based on chromosome 1q gain, which is in a more recent analysis, we have shown that the adjuvant radiation therapy, immediate adjuvant radiation therapy, can provide excellent 5-year and 10-year overall survival and local control in these patients, as much as 70% 10-year overall survival in a grade 2 ependymoma compared to grade 3, which can dip to about 50%. And from Dr. Daniel Indelicato from UFPTI, we know that this was the largest study of 386 children, wherein they looked at comprehensively failures of ependymomas beyond 3 years of follow-up, dosimetric concerns like marginal miss, reduced local control due to miscalculation of the RB and other things. And they have demonstrated improved overall survival, local control of close to up to 80-85%. Although this was a mixed bag of ependymomas, it had both posterior fossa and supratentorial. GTR at the time of radiation gave significantly improved survival, and females did better compared to males. And failures of 65 patients out of 67 non-metastatic recurrences were in field and 2 were marginal. So brainstem injury is what one of the important components of this ependymoma data from UFPTI came, and these are the dosimetric outcomes what we try to achieve. 0.1 cc, we try to keep it at 56 gray and maximum of 58 gray. 10% should not get more than 55.4 gray, and 50% of the brainstem should not get more than 52.4 gray when the RBs are calculated at 1.1. And you make sure that there is no ending of the beam on that particular area. Either it traverses through or it is distributed across 4 or 5 different beams. So our own experience, this was a little older data. So we have 31, we have close to 50 children. As I told you previously, recurrent ependymomas here, especially the posterior fossas, they all receive crinospinal irradiation. Recurrent ependymomas in a supratentorial fossa, if we identify that apart from the Zefta fusion, if they have CDKN2A, 2B co-deletion, which is acquired over a course of time, then we try to give them crinospinal irradiation. Apart from them, the outcomes of focal RT as well as crinospinal irradiation has been quite encouraging, and we are in the process of final analysis and submission into major leading journals. So last few slides on intracranial germ cell tumors. We know germinomas are treated with chemotherapy upfront, and we give whole ventricular RT to a dose of 40 gray, especially except in few circumstances where geminoma is close to the corpus callosum or the basal ganglia or the skull base. In a non-geminomatous germ cell tumor, you give chemotherapy and then you give 30 to 35 gray CSI based on whether it is a yolk sac tumor or a choriocarcinoma, and then you boost to the most bulky site and the metastatic sites. And if there is a residue at the end, you try to do surgery wherever feasible. So in an intracranial germ cell tumor, there has been a significant shift of care. We try to reduce as much toxicity as possible, try to provide as much less toxic regimens of treatment for these children so that we have got long-term outcomes and improve their quality of life. So one such case, and most of this data of comparing IMPT with 3 millimeter spot sizes compared to IMPT of 8 millimeter and PBT and IMRT, especially from Mass General Hospital, has shown that significantly improved neurocognitive outcomes in children if you did with the smaller spot size IMPT compared to a larger size. So one such case of a germinoma, wherein we had a disease coming from the basal ganglia in a germinoma, and so this child required a crinospinal irradiation, and we have this child who is about 6 years on follow-up with IMPT giving 40 gray, 23 fractions, and about 14 fractions to the whole CSI and 16.2 to the disease. And such cases have been many. I would like to show a few slides on optic nerve sheath meningioma, optic nerve gliomas, either the optic nerve or the optic chiasm or the cerebellar low-grade pilocytic astrocytomas. We as a group were able to identify that a particular imaging biomarker called amide proton transfer, which is a type of perfusion scan, can have a classic mismatch repair compared to a ASL perfusion scan, which can be used as a diagnostic biomarker for identifying pilocytic astrocytomas. I have put here one such case as a pilocytic astrocytoma, which is identified with this technique called APT on the MRI. And what we can see here is a cerebellar pilocytic astrocytoma in I think in a 12-year-old girl with options of systemic therapy. Of course, they are there, but in a country like India, wherein most of the patients cannot afford to receive systemic biological therapy with a BRAF inhibitor or a MEK inhibitor, can be extremely costly. we do cost-effective ways of giving them proton therapy so that we reduce the toxicity. And you can see that over time there is significant improvement in these cases, and you can see that almost complete response. And most of it is identified on a good quality MRI scan pre-radiation, and then we customize it, and then we make sure that we give optimum radiation therapy without causing much toxicity. So especially when there is a dilemma of using adjuvant therapy, whether it's systemic chemotherapy or targeted therapy or a focal conformal radiation therapy, I don't think a location of the pediatric low-grade glioma really matters because of the shrinkage of these tumors over time, what we have demonstrated, and also effective holistic neuro-oncological management. Finally, coming to radiological toxicity, I've taken slides. I've taken these images from papers published in the in leading journals of radiation oncology. I think most are from Mass General Hospital and one from Stanford. You can see the side effects of radiation therapy with proton therapy, especially can be a simple periventricular white matter hyperintensity, can be a deep white matter hyperintensity, can be a resection cavity white matter intensity. So what people have tested is, although you bring radiation therapy from only 2 or 3 different proton therapy from only 2 or 3 different directions, the changes of these can keep evolving over time, and at times this can be due to a high LET radiation deposition. What people have tried to do of late is they are trying to do something called as a dose averaged LET or a voxel wise dose versus LET to look at the effect of end range of these proton beams and try to quantify these and try to map these areas of high LET and try to map them with on the follow-up MRI scans to see where exactly these white matter changes are happening, and thereby making the plans more optimal so that you can reduce the chances of end range uncertainties and LET based depositions in these patients. So finally, my last slide. So modern proton therapy has been compared with has been tested in a cost-effective modeling from various countries. One such I have tried to put here. We also have done a few models of this sort. What they have seen is, in a child with medulloblastoma, you give conventional radiation therapy with CSI and tumor bed boost. Over time, there is a lot of replacement that these children need, like the hearing loss has to be corrected, hypothyroidism, osteoporosis, growth hormone deficiency. There can be secondary malignancies and fatal events. And one such model on incremental cost effectiveness ratio has shown that in US dollars, proton therapy can significantly reduce close to 30,000 USDs, which is an American model. The same is not true with Indian model. Of course, it can be much less. That proton therapy can be beneficial in these group of children, especially like an average risk medulloblastoma, wherein you are looking at a complete cure, and over age or over follow-up, like about 5 years or 6 years or 10 years, while these children develop significant deficits and complications because of radiation, the cost spent on these complications, along with radiation costs and chemotherapy costs, when you add it over time and compare the same thing with proton therapy, which gives less toxicity, it seems like proton therapy is much cost effective compared to conventional radiation therapy. And especially when they looked at two aspects, one was the hypothyroidism and one was a sex hormone deficiency, and also the final height of these children. They found that children with proton therapy had significantly better cost effective treatment eventually compared to conventional radiation therapy. And we also have been trying to do such models, and maybe in a year or two, we will have most of these results published, because now the chunk of patients have been collected and we know exactly the costs spent over time. So with that, I would like to conclude my talk, and I would like to thank for all your patient hearing, and I would be happy to take any questions.
Thank you so much, Dr. Krishna. I think we'll see if any of the audience have some questions for you. I'm checking also the chat log.
I have a question. So they thank you. Thanks so much for joining us tonight and providing this excellent experience that's coming out of India. I think we have a lot to learn from experience. It's very great to see that India is leading the way in terms of research for low and middle income and resource countries. Some countries are high income countries, but we're still resource constrained in terms of technology and in terms of expertise. So I think the biggest thing I can take from your talk personally is that I should be pushing more for children to get proton treatments. I know that in terms of toxicity, and I think I draw the parallel between the days of 3D conformal and the days of VMAT, where people were the only argument for VMAT was reduced toxicity, right? Although the expense in terms of investing in a proton therapy, it's a one-time expense, but it brings a lot of value to the country. So I think what I'm really eager to know about is the modeling for India, because that's the argument for us, is would we consider investing in this technology in Saudi Arabia and bringing proton therapy to Saudi Arabia, or you could just send patients abroad for treatment for proton therapy. Did you feel that it made a huge difference investing and building the technology in India? That's number one. The second question I have is, in terms of modeling, do you think in terms of toxicity versus expense, would that make sense for low and medium income countries or high income countries with constrained resources? Thank you, Ade.
Yeah, thank you so much for invitation. And then it was very pleasure to be talking to this crowd. So to answer to your first question, before when this proton therapy started, I was working at a tertiary care cancer center with photon technology alone, and I was sending patients here for referral because of my training from Paul Scherer and also from other places. So what I understood was, if we carefully choose patients and if we make the families understand that this is significantly going to improve the outcome over the next 5 years, and not all children are definitely going to benefit with proton therapy, that we have to understand. But wherever possible, if we try to explain the families, I was working at a different center and not Apollo, and I realized that if you try to educate these families, definitely they are going to understand the cost implications of this, which is like a one-time payment. But having said that, in our center, what we have tried to do is we have got various groups of patients. There are many patients who are being referred from a government hospital in which most of them have got out-of-pocket expenditure. We try to subsidize proton therapy to close to about 30 to 40% of what it is. Not just from India, but also from all of the neighboring countries. We try to reduce the cost to about 30 to 40%, because a child with an ependymoma, for example, has got adjuvant radiation therapy as the only solution for it unless it recurs. So in that situation, the most important consideration is to give less toxicity, and I think proton therapy has to be given to any child irrespective of cost. So the second tier, this is the first tier for very poor patients who come from a government and a subsidized setting. So in them, we try to crowdfund, we try to help them family from Apollo itself, or the family tries to gather money, and then we try to do something. The second group of patients are borderline indications like a optic pathway glioma, which has failed on multiple lines of systemic therapy, or it could be a child with a cerebellar pilocytic astrocytoma, in which child already has got significant deficits, and we may not really have much time to offer for this child with systemic therapy. That is the second tier, where we try to explain them. We try to run both the photon plan and the proton plan, and we try to compare and show them that proton therapy is significantly better. And of course, the third group is a high income group which can afford proton therapy. And here we try to even treat brainstem gliomas who are biopsy proven pilocytic astrocytomas with proton therapy. So we have got these three sort of sectored selection of population of children, and wherein we try to run various situations. We don't have a classic model system here to answer your second question. But what we try to do is we try to take model policies of both the Netherlands as well as US astro model policies, and try to mix and match with our own experience, what we have done here, and try to select a case population and then give them proton therapy whenever feasible.
Thank you so much, Dr. Krishna. I think we have a question from the audience in the chat log. Given that proton have similar RBE as photon, we could explain the less toxicity or complication. But how this has been reflected on OS or PFS?
Yeah, so I understand that the question is has been generalized. So if I can take this question for say medulloblastoma with an average risk medulloblastoma, wherein you are looking at a completely resected tumor like a group 4 medulloblastoma. Let us take a group 4 medulloblastoma, wherein we know that this child needs adjuvant radiation, cranospinal irradiation completely, and then a tumor bed boost. So if you look at the toxicity to supratentorial brain, which can be an additional toxicity in for a child who is yet to go to chemotherapy, has to receive complications, who has to receive chemotherapy, which also can add on to the toxicity of radiation. Maybe it is cyclophosphamide or a platinum. Definitely, it is going to benefit on the overall survival of this child. If I look at a situation like a ependymoma, wherein there is a small residue left behind, which was inoperable, instead of giving chemotherapy for this child, if you can try to push more dose and try to reduce the brainstem dose because of the end range of the proton therapy, and if you can try to push more doses of about 56, 57 gray in this child, which cannot be possible on the photons, it is definitely going to give you a higher PFS. So the PFS and OS benefit of proton therapy has to be chosen case basis on situations and cannot be generalized for all situations.
So that's all from the chat log, I think. Does anyone from the audience has any more questions for Dr. Krishna?
I have just a question. So a referral process, Uday, for Apollo in terms of patients who are speaking Arabic. I've seen that you've had a few patients who are coming from Gulf countries. I've had a few patients that I referred personally to Apollo, adult patients, but I'm not sure if you have like a way to facilitate this process, because we do have a lot of patients. So the Saudi government can fund some of these patients to go to contracted hospitals in the US, Germany. I don't think Apollo is part of these contracts yet. Maybe you could consider applying to the Saudi Ministry of Health to see if there is a process to facilitate this. The other thing is how could we, if you have a point of contact or someone, because I do treat patients who are non-Saudis, patients are from Yemen or from other parts of the Arab world. We don't have any functional proton therapy, unfortunately, in as of now in West Asia, even including Iran, Turkey, North Africa, and the Middle East. So I was wondering if you guys have someone who speaks Arabic or a good point of contact, and if you can speak more to the referral process to Apollo.
Yes, so we have an international team, which a dedicated person for UAE and Saudi Arabia. So I would like to write to him, and then I would like to see how we can take the opportunity of trying to convince the Saudi Arabian government to fund these children. Maybe we can show our own results. Maybe we can have our own discussions of projecting outcomes of our own patients being discussed in multiple international platforms, which has been accepted internationally, globally, peer-reviewed publications, so that they can be impressed with the results here. Second thing, I think, was the Arabic translation. We have got patients coming routinely from other parts of the Middle East. So we have regular Arabic translators here, so who can talk to the families and who can facilitate their shift here. So I can request my international team vice president to be in touch with you so that we can take it forward and we can see how to make collaboration better. On a personal basis, if you think that if there is a family who would really benefit from proton therapy, you can write to me. I can talk to them, arrange a proper organized video consultation, and then we can talk to the family. We can do the planning. I can involve you in the planning stage, evaluation stage, and also at the delivery stage, so that the family is comfortable and understands that you are the primary caretaker and we are trying to facilitate the proton therapy here. Even that is possible.
Yeah, that's
It's
a
actually
very great
excellent.
idea. I think it's
That's actually a great idea, absolutely.
yeah. So usually when we refer patients in Proton Center, we feel just disconnected, and the patients themselves, and we don't have that, this in handy. So it will be very helpful even for the patient to be convinced of the proton treatment plan.
Yeah. So we have had a lot of word of mouth referrals. The families who have come here for treatment, for example, the families from Syria, from Egypt, who have migrated to UAE. So word of mouth ependymomas, especially, they would want to know more about proton. So we have treated some of the very sick children who require tracheostomy, who required care under GA. So the anesthesia team is fantastic. The pediatric ICU is fantastic. So even if a child has to be airlifted from there to here, we have tried to manage. We have seen them improving. So so it all takes a lot of personalized care, which I think is available here, and we'll be happy to provide it to any child from your region at any given point of time.
Just a final thing. So I promised you that I'll be visiting you in Chennai, and hopefully I fulfill my promise maybe in the next few months or next year. The other thing is we'd love to host you for our next SARO meeting, which usually happens sometimes in May. Maybe if we have a few of the group from Apollo visiting us and showcase your experience, because the other thing we're trying to do is we want to invest in the technology locally. I mean, for the time being, we can collaborate on treating patients because there is growing patient needs, but also we need to see how you guys went about, using the private sector investment into proton therapy in India. If you say to someone that I'm going to invest in proton therapy in India, they'll say, you should be investing in other technologies where you have more access. But I think you bet on the winning horse. I think investing in proton therapy in India was the right move, even for a private group like Apollo. I think you provided excellent care. I've worked in proton centers abroad in the US, and I can attest to Apollo. I am pretty sure that you're on par with the leading institutions worldwide. With your experience, expertise, and all the things that you provide everyone. So consider this an official invitation to you to visit Saudi Arabia. We hold our meeting in Jeddah, which is the second largest city in Saudi Arabia. It's a very nice area. It's more or less closer to the sea, so it's a nice place to visit. Thank you, Dave, very much.
Thank you so much. Namaste.
Okay, see you soon.
Yeah, bye.
Yeah,